I'm Dr. David Kraus. I'm the Chief Medical Officer of Genomind, the pharmacogenetic testing company. Most of you will know us by now. And welcome to Grand Rounds. Today, we're really privileged to have our newest SAB member, Dr. David Nash. Dr. Nash is a force of nature within the world of public health and health policy. He's the founding Dean Emeritus of the Jefferson College of Population Health, where he's also the Dr. Raymond C. and Doris N. Grandin Professor of Health Policy. Dr. Nash's CV is far too long for me to read now, but Dr. Nash is an internist by training, and he's an internationally recognized expert in public health outcomes, physician leadership development, and quality of care improvement. David has received many awards in recognition of his achievement. He received the top recognition award from the Academy of Managed Care Pharmacy, Philadelphia Business Journal Healthcare Heroes Award. He is an honorary distinguished fellow of the American College of Physician Executives. Wharton School of Business honored Dr. Nash in 2009 with the Wharton Healthcare Alumni Achievement Award. He is the author of more than 100 peer-reviewed articles, and he's the editor of 25 books. He's currently the editor-in-chief of the American Journal of Medical Quality and several other journals. Dr. Nash received his bachelor's degree in economics from Vassar, where he was Phi Beta Kappa. He received his medical degree from the University of Rochester School of Medicine and an MBA in Health Administration with honors from Wharton School. So we're very privileged to have you, David, and looking forward to hear what you have to say about the intersection of population health and precision medicine. Thank you for joining us.
Well, thank you, David. Great to be together. Special thanks for everybody for carving out time on a busy Friday. I really, really appreciate it. And it's a real privilege to be on the Genomind External Advisory Board. And thanks to Alexis Miles and Rebecca Williams on the team for all their help getting today together.
So, David, I just want to interject one thing.
Sure.
The audience, you may pose questions using the Q&A button at the bottom of your screen. You won't be able to ask questions out loud. If we have time at the end, I will moderate a Q&A. Sorry.
No problem. And just once again, I really appreciate everybody taking time on a Friday at lunchtime. So I was asked, given my background, to tackle a couple of things, but the title of our time together, Population Health and Precision Medicine, Friend or Foe? Let me give you the punchline up front, definitely friend. In fact, we're going to introduce some new terms, including a term that's gotten a lot of play, especially in the past year, and that is, we're going to call it precision population health. So here's how we're going to divide our time together today. We're going to do three things. Part one will be a little bit of a context, a definition, vocabularies, basically the ecosystem that we're currently in. Part two, I'm going to define population health and explain what those pesky social determinants are, why they're so important. And then in part three, we'll bring it all together, population health, precision medicine, and we'll talk about the future of precision population health. Genomind is perfectly situated, in my view, to take advantage of this nexus now of population health and precision medicine. So one more time, three parts. Part one, how do we get into this current situation? Part two, population health, and part three, precision population health and a view towards the future. So first, I'm going to advance my own slides, and I know this is a little scatologic, but I wanted to let everybody know this is a real live poster approved by the CDC on a subway station in Midtown Manhattan. I won't read it to you, but I think that definitely aligns with my perspective, and it sort of speaks for itself. And if anybody wants a copy, I'll be happy to send it to you when we're done. But more importantly, to set the context, let's think about the history of how we got to where we are. So I could read the following verbatim statement from the founding meeting of the American College of Surgeons over 100 years ago at the Waldorf Astoria Hotel in Midtown Manhattan during World War I, when all these guys, no girls were present, said that all hospitals are accountable to the public for their degree of success. And if this initiative isn't taken by us in the medical profession, it will be taken by the lay public. Unbelievable that this is over a century ago. And from an internal medicine perspective, amazing that it's a bunch of surgeons who had the prescient worldview to issue a statement like this. We're going to come back to this at the end of our time together because it's all about the notion of transparency for outcomes and accountability to the public. So let's put those two words in our head, transparency and accountability. That's the theme. And these were amazing guys over 100 years ago thinking about these critical issues. So where are we today? Well, let's again, part one, ecosystem. I think it's really important for us to remember that employers are still paying more than 50 cents of every dollar for healthcare. The remainder is paid for by Uncle Sam, either through Medicare or Medicaid. So this is a cover of what was then called Business Week magazine. Now it's Bloomberg Business after Mike bought the company. But the message here is this cover is pretty darn amazing. And it says medical guesswork from heart surgery to prostate care. The medical industry knows little about what treatments really work. And for all the clinicians who are joining us today, you know exactly what this cover is about. That we know that basically we only have grade A evidence 18% of the time, plus or minus 2%. In other words, 1 out of 5 times, we really have a pretty darn good evidentiary basis for what we're doing at the bedside. 4 out of 5 times, we're sort of guessing and winging it, or what you and I would call the art of medicine. The challenge with this art of medicine is that it's very expensive, it's highly variable, outcomes are all over the place. Oh, and aspects of it are dangerous and wasteful. So the people who pay the bills from the private sector, large employers and small employers for that matter, they're onto us. And I want to put this notion of variability into our vocabulary as well. And we'll return to this theme. Main message from this classic teaching slide. Well, 18% of the time we have grade A evidence. The rest of the time we're using our experience, our intuition, our best guess. And of course, we're not making widgets in clinical medicine, and our substrate are people, not technology. So this is a real challenge for us. Another challenge in really important magazines that regrettably my wife and I are now regular readers of the AARP bulletin, but this is another classic teaching cover story from the AARP that says doctors say, skip these tests, PSA screening, routine EKGs, bone density scans, and all the rest. The take-home message from this slide is to reinforce the issue. There's a lot of waste out there. Why is there waste? Well, not everybody fits a certain category. Lots of folks do what they were trained to do, despite the fact that the evidence might not be there. So for example, PSA screening, that's not what this presentation is about, but I can remember when my late father-in-law at age 85 went to his primary care doctor in Florida, and that knucklehead ordered a PSA test on Grandpa Harry. Well, of course, his prostate was the size of an underinflated basketball at age 85. Was it mean-spirited that he ordered that PSA? I don't think so. I think a medical assistant checked the box and it was paid for by Medicare. You get the idea. Routine screening for cardiograms and bone density. At this moment, all kinds of inappropriate EKGs are being done. How come? Well, one person's inappropriate testing is another person's income stream. So no matter what field we're in, I think the take-home message is there's an awful lot of waste in our system. So I want you to think about accountability, transparency, and waste. And we'll foreshadow where we're going to be in part 2 and part 3, that one of the beauties of precision medicine is to reduce waste in the system. Another way to look at this is, I was told 30 years ago that the most important thing we could overcome in healthcare was to reduce unexplained clinical variation. What exactly is that? Well, unexplained clinical variation is a very polite way of saying Doctors do what we're trained to do. Now, that means that Dr. Krause does it his way, Dr. Nash does it his way, and Dr. Jones does it her way. And that's because we all went to 3 different medical schools, had different mentors, different training environments, and we're all convinced of the value of how we do it. The sad part is that we've lacked closure of the feedback loop. We've lacked access to data on the outcomes that we were able to achieve. And so unexplained clinical variation is a nice way of saying there's unbelievable variation in what we do for the same diagnosis, keeping clinical issues constant. As a result, unexplained clinical variation is a roadblock to lowering costs, improving quality, and very importantly, a la 1918, establishing accountability. How can we be accountable if everybody's use of resources and outcomes are totally different for the same diagnosis? Makes no sense. Another way to look at this is the amount of waste in the system. So this is, you've all seen diagrams like this. This is from our colleagues at Price Waterhouse and Johns Hopkins. It's a tiny bit dated, but the numbers haven't changed dramatically, except to say now we spend $3 trillion on healthcare instead of 2.2. But waste basically comes in 3 varieties, and you can see it right on this wonderful diagram. There's behavioral waste, gigantic, and we'll come back to that. Obesity, alcoholism, depression, opioid abuse, all the 4 horsemen of the social apocalypse. There's clinical waste, unexplained variation, medical error, hospital-acquired infection, and of course, there's operational waste, and all of our clinical colleagues know about this. This is going home and still working on your epic charts from home, despite an entire day at work. Take-home message. There's probably more than $1 trillion of waste in our system, and waste comes in 3 varieties. Behavioral, more on that in a moment, clinical waste, variation and error, and operational waste. If you put it all together, more than $1 trillion of waste. So, you know, in an industry the size of ours, and by the way, we're the biggest business in America. Let's remember 20% of the GDP. The military industrial complex in the US is roughly 7% of the GDP. So we're 3 times the size of the military industrial complex, making us the biggest business in America. And in Philadelphia, home of 4 medical schools, medicine is the #1 local industry. So in an industry with about $1 trillion of waste, that attracts all kinds of attention. We'll see more about that in a minute. Another message that I want to give you is from my fantastic colleague, Dr. Brent James, formerly at Intermountain Healthcare in Salt Lake City, member of the National Academy of Medicine, one of the key authors of the 2 critical books 20 years ago, To Err is Human from the National Academy of Medicine, 1999, Crossing the Quality Chasm, 2001, National Academy of Medicine. These books, despite being 2 decades old, laid the groundwork for our work here today. And in his testimony on Capitol Hill, Dr. James has said the following 5 things. Let's go over this quickly. Massive variation in clinical practice. Well, we've already nailed that one. High rates of inappropriate care. Everywhere but your hospital and at Jefferson, there's inappropriate care. Everywhere else, there's inappropriate care. Unacceptable rates of preventable care-associated injury and death. I'll show you some data in a minute from Marty Macri and others at Hopkins. We have been talking about this since 1999, roughly 400,000 preventable deaths annually. That's right, from medical error. Number 4, striking inability to do what we know works. Well, this is a complex notion having to do with complexity of systems and all the rest. We'll come back to that. And then finally, huge amounts of waste leading to spiraling prices that limit access to care. So main message so far is a pretty dim picture. 18% of the time we have solid science at the bedside. We all were trained to do it the right way, but we can't all be equally correct. And there's about $1.5 trillion worth of waste in the system. So it's a setup for the need for precision, a setup for the need to improve, a setup for the need to reduce error. Here's the work from the British Medical Journal and Marty McAree, Jefferson Medical College graduate, one of my former students, pretty incredible. And Marty's gone on to have a distinguished career at Hopkins. And in their follow-up analysis to all the original work into error is human, what's the take home? Well, sadly, despite COVID, medical error remains one of the top 3 or 4 leading causes of death everywhere but Jefferson in the United States. So colleagues, we're in a jam. We're spending a lot of money. We have a lot of waste. We're hurting people. Certainly, we could all agree, whatever our politics or perspective, we could all agree we could all do a better job. That leads us to part 2 of our time together. And as advertised, what I want to do here is give some background and history about population health, which will enable me to connect the dots in part 3 of our time together. So isn't this a wonderful picture? Here is this handsome house officer precariously balancing on these 2 canoes, and on your left, he's got the red REI backpack, historical and current fee-for-service, and on our right, value-based payment, population health management. And the way I see it, he's got 3 choices, right? Choice 1, he could just jump into the canoe, historical and current fee-for-service, and sail off. What he doesn't realize is about 100 yards downriver is a 1,000-foot waterfall, and he is going to perish. Choice 2, he could jump in the drink and call it a day. And at age 66, now I'm Medicare eligible. Many of my clinical colleagues have decided at the same age that's enough, and jump into the drink, and that's the end of the story. Or he could jump into the canoe and sail off happily into a future based on payment related to outcomes, so-called value-based payment, practicing population health management. So what does all this jargon mean? That's what we're going to focus on in part 2 of our time together. But surely the picture says 1,000 words, and this is a great summary of where I believe we're going. So when did all this really start? Well, amazingly, almost 5 years to the day. Look at this great cover of USA Today, the most important medical journal, February 27th, 2017. And here we are today, amazing, February 25. So 5 years ago today, USA ran a page 1 story, and you could read the headlines that were a shocker. 5 years ago, hospitals look to profit by keeping patients away. So at that point, we were 7 years into Obamacare, right? So let's get our history straight. March 2010, whatever your politics, Obamacare gets passed. We create accountable care organizations. We start the journey toward value-based care. We start rewarding hospitals and insurance companies to keep people healthy and out of the hospital. This was the first page 1 story in a major American newspaper, in my view, that helped to get the point across, to educate folks about what did we mean by value-based payment. And here they focused on our colleagues at Christiana Care in Delaware, in the United States, of course, but an amazing pivot. So we started with this, we went to this cover story 5 years ago, and now let me give you some of the background about population health. Well, again, colleagues, whatever your politics, sort of irrelevant. In the rest of the Western world, the spending that goes towards social spending has a greater impact on improving health than the spending that goes towards healthcare services. Let me put it another way. In the rest of the developed world, nobody spends 20% of the GDP on healthcare services. Monies go toward food, housing, healthcare as necessary, but prevention, not so much high technology. And it turns out that the US is an anomaly in terms of how we spend money and how we promote health. We'll come back to this in a moment, but it's very, very important. And our attendees know today that sadly, average life expectancy in the United States has been in reverse gear pre-pandemic. In other words, for the first time since World War II, for the first time since 1945, generations that come after me, millennials and so on, my grown children have a shorter life expectancy than my baby boomer wife and me. Well, that is an untenable situation. And if you look at the rest of the developed world, they have tackled this by putting spending where it creates health rather than spending where it drives utilization. Well, and this contributes to a pattern of waste, a pattern of unexplained variation, and a pattern of medical error. This is not David Nash's opinion. This is well established in the health services research literature over the last 15 years. What else do we know? Well, this is our great city of Philadelphia, even though the slide comes from Virginia Commonwealth University. My office is just about at this intersection of the two main roads in downtown Philadelphia. But the point here is that geography is destiny as it relates to your life expectancy in America's fifth largest city. So a little bit of background. Zip code, as you now appreciate, is more important than your genetic code when it comes to predicting life expectancy. In Philadelphia, if you're lucky enough to be born and raised in Society Hill, walking distance from my office in downtown Philadelphia, you have an average life expectancy of 88 years, a pretty robust life. If you're unlucky enough to be born and raised in North Philadelphia, about a 5 or 6 mile taxi ride from my office, you have an average life expectancy of 68 years, a 20-year discrepancy in life expectancy in one city. And what's the principal driver here? Well, as most folks probably know by now, poverty. Poverty exacerbated by crime, by poor housing, by decades of structural racism, and a host of societal problems that we can't resolve in this call. But there is no question that zip code is destiny. Zip code is more predictive of your life expectancy in America than your genetic code. This is all part of population health. So let's talk about population health. Where did this term come from? Can we give a good definition? So here is about the best model for population health that I could find. And this comes from our colleague, Dr. David Kindig, Kindig, still alive and working at the University of Wisconsin in Madison at the Population Health Institute. And this, colleagues, is from his 2003, unbelievable, his 2003 paper in the American Journal of Public Health, where he first introduced the term population health, 2003. As David Krause noted half an hour ago, it was a real privilege for me to be named the founding dean of America's first College of Population Health way back in 2008. We opened the doors to our college in 2009. We wrote the first textbook on population health. I'll show you a picture of that in a moment here in part 2. But we got to give credit to David Kindig, who in 2003 said the following: well, population health, here's the conceptual framework. So there are health outcomes that are distributed within a population. You know about this: morbidity, mortality, and quality of life. Then there are determinants that influence these outcomes, like medical care, certainly, the laying on of hands, socioeconomic status, zip code, poverty, crime. Genetics, meaning choosing your parents wisely, could have a big impact on your health. And then there's policies and interventions which influence the determinants which drive the outcome. Social policy, Obamacare, environmental policy, climate change, and individual behavior. Now, remember, we looked at waste, and waste has individual waste, clinical waste, and operational waste. So what's the message? Well, the message here is these roughly 9 factors: morbidity, mortality, quality, medical care, you get the idea. These 9 factors go into sort of a witch's brew to determine health. And here's what it looks like. Amazing. On the left, what makes us healthy? Well, access to medical care despite the fact that there are 4 major academic medical centers in Philadelphia, that's not the key to improving health. That's 10% of the story. 20% of the story is mom and dad. Another 20% is the environment. But the vast majority of what determines the outcome is our own individual behavior. How we spend money in Philadelphia and writ large the US, roughly $3.5 trillion, 20% of the GDP. How we spend money is mostly on medical services, a tiny portion on improving healthy behavior, and then a mishmash of other stuff. Main message, sadly, counterintuitively, somewhat upsetting for a Friday in February, it ain't about medical care. In fact, that's a small part of the story. It's all about crime, poverty, individual behavior, structural racism, and all the other complex social challenges. Sure, if you have an emergency or you need surgery or a big technologic procedure, America is a great place to receive care. But if you're looking for a nation that values and invests in keeping people healthy rather than treating acute and episodic problems, well, we are not the nation, we're not the model, we're not the world leader in keeping people healthy. Clearly not. Especially in light of smoking, firearms, depression, suicide, opioid addiction, and all the other major societal ills, all of which have a huge impact on health. Another way to look at this is a diagram as follows. So we have a mismatch, right? On the left is what the US spends versus what makes us healthy. It's just another way of looking at the same data slice. 88% of the spending goes to medical services, 4% to healthy behaviors. What actually makes people healthy is our behavior, the environment, the whole person approach. Another way to look at this, here's a slide from Big Bad Humana Insurance Company, and say whatever you will about the top 5 major for-profit insurance companies. They practice population health. How come? Well, they have every economic incentive aligned to keep people healthy and out of the hospital. Let's tell a quick story. When my late mother was alive and well in Florida, she was a Humana patient. And Humana routinely sent folks to her home, not only to make sure she was taking all of her medication, but at one visit, they took the shag rug out of mom's bathroom. How come? Well, they knew that that shag rug put mom at risk of a fall. And if mom fell, she was going to break her hip and Humana would have to pay for her hip repair. Now, can you see Jefferson Hospital sending a medical assistant to mom's house to take her shag rug out of the bathroom? I don't think so. So if you align economic incentives and you literally connect the dots, like on the right side of this diagram, you promote accountability, you promote value, you start to knock on the door of practicing more of a population-based care. By the way, they also picked mom up in a van pre-pandemic, took her to the senior center where she met other moms. You get the idea. So look, population health in its theoretical and conceptual background, going all the way back to 2003, essentially says it ain't about the laying on of hands, dummies. It's all about how we organize ourselves, where we make investments. In a word, we go upstream to shut the faucet rather than constantly mopping up the floor. Instead of building another cardiac cath lab, we go and promote nutrition. Instead of building another bariatric surgical suite, we go upstream to promote healthy behaviors and get people to reduce weight. That's what this is all about. And of course, this is an incredibly complex process. Another way to look at this, as I alluded to, back in 2009, when we opened the doors to our College of Population Health, imagine having a school without a textbook. How could you do that? So we had to put together the first textbook in population health. This is a cover of the current and 3rd edition of our book. We were so excited to put this together, and it's a topic for another time. But of course, I would love to see everybody read a copy of our textbook, Population Health, Creating a Culture of Wellness, where all of what we just talked about is go into great detail. our scholarly peer-reviewed journal, which has been around now for more than 15 years, appropriately called Population Health Management. So look, these are resources for you at any time. I'd be happy to give people more detail. Main message: population health is a bona fide scientific field today with a serious research foundation to support our work. Let's turn now, we're still in part 2, what's population health, and then we'll get to part 3, connecting it to precision medicine. But let's go back to that diagram about waste. Remember, there were 3 types of waste: individual behavior, clinical waste, unexplained clinical variation, and operational waste. Now I'm going to show you a little bit about waste from an individual behavior perspective. So here he is. This is, of course, Michelangelo's David in the Uffizi Gallery in Florence, Italy. This is the 2022 version of the famous Michelangelo statue. What do we know? Well, we know right now in our great country, 40% of all women over 18 and 30% of all men over 18 are obese according to their BMI. Let's do that again. 40% of all women, 30% of all men, adult women and men. I mean, this is staggering. The numbers have not improved. And since COVID, the numbers have worsened with people sitting home. In fact, it's sometimes referred to as the COVID-19 pounds. So let's delve a little deeper into what might be some of the sort of the sources, the etiology of this obesity epidemic, which has major impact on the healthcare system, contributes to waste, contributes to poor health. So here's a quiz, and I'll give you the details, and then I'll wait a second, and I'll give you the answer. So colleagues, what percentage of adult Americans do the following 5 things? And you got to do all 5. There's no partial credit. Let me run through these. I'll give you 2 references, and then I'll give you the answer. So what percentage of adults exercise at least 20 minutes 3 times a week, don't smoke cigars or cigarettes, eat their fruits and vegetables like their mother taught them, wear a seatbelt, and will say are close to an appropriate body mass index? You got to do all 5 things. The research comes from 2 articles. Let me give you references: Annals of Internal Medicine, the University of Michigan Social Science Research Institute, way back in April of 2006, and another study, University of Oregon in Eugene, 2018, same answer achieved in 2 studies 12 years apart. So drum roll, what percentage of adults do all 5 of these things? And the answer is, are you ready? 3%. That's right. 3% of adult Americans of both sexes do all 5 of these activities. Is it any wonder, colleagues, that we have an obesity and poor health epidemic in our country? So this is a big part of the challenge, realigning economic incentives to tackle these issues like exercise and smoking and nutrition. This is where we've got to go. For the clinicians in the room, I won't ask for a show of hands, but who here has had graduate level training in exercise physiology, behavioral economics, nutritional counseling? I mean, this is not the cornerstone of even current primary care training. So the key determinants of health remain the following: stop smoking, improve your diet, get moving, and reduce alcohol consumption. Today, if you were to make rounds in America's community hospitals, 40% of all deaths pre-COVID are attributed to the long-term effects of these 4 things: smoking, diet, lack of physical activity, and alcohol. Pretty darn incredible. Most of this, of course, is preventable. So by realigning economic incentives, focusing on these issues, going upstream to shut the faucet rather than mopping up the floor, we could have a big, big impact on health. We would still be faced with waste, medical error, inappropriate and unexplained utilization. So that gets us to the transition to the 3rd and final part of our time together. And to do this transition, I need 2 slides, and let me show you what we're talking about. So perhaps you've seen something like this. Let me describe what's going on to our clinical colleagues, and I'm sure you've seen something like this in the last year or two. So look, we're moving on the x-axis to a world where clinicians are mandated to bear greater risk, of course, with MACRA and APMs and all the rest, and some type of capitation. This means we are at economic risk for the clinical outcome. And on the y-axis, that's quality. So where we're hoping to go is by bearing greater economic risk, by focusing on improving our own performance. Let's go to the right-hand side of the diagram. So what will a high-performing delivery system, the Jefferson of 2024, 2025, what will it look like? Well, we're going to utilize predictive modeling. We're going to manage utilization. We're going to optimize efficiency. What does all this really mean? Well, we're going to hold clinicians accountable for their decision-making. It'll have to be evidence-based. We'll have to close the feedback loop. We'll have to reduce waste. We'll have to reduce error. And I would submit one of the ways we're going to get to coordinated high-performing care is through precision medicine. That's right. It's not even on this diagram when this was created now 3 years ago. Here's another way to look at the same transition. Let me try another slide. So you've all seen this. We are now in the second curve. So most of us were trained in the fee-for-service, pay-for-volume, the more we did, the better world, like I was 40 years ago, and like David Krauss was back in the Civil War when he went to medical school. And now we're in the second wave, where it's payment based on value. There's systems of care, providers are at risk, and we have to align physicians to engage in this process. And what I am submitting to you in part 3 is that the way to engagement, one way might be not only aligning economic incentives, but I want to introduce in another moment the term precision population health. So let's transition to that. So we're going to tell 2 stories to make the transition to the final part of our time together. This is a map of the great Commonwealth of Pennsylvania. Looks like a big rectangle, of course. And there are 67 counties in our great state. Jefferson University is in Philadelphia County in the far lower right, of course, where it says PH. And this is a map using data from the Robert Wood Johnson Foundation to rank the health of persons in each of the 67 counties in our great state. And colleagues, here's the sad outcome of this work, that persons in Philadelphia County, home of 4 academic medical centers, including Jefferson, Philadelphia County ranks dead last, 67 out of 67 with regard to the health of the persons who live in our county. So what's population health reconciling this mess? How could it be that a county with all those resources devoted to delivering healthcare services ranks dead last in terms of the health of the population? A pretty scary state of affairs. So population health intends to tackle this question. Now, here comes the big question to get us to the third and final part of our time together. Are we at the Malcolm Gladwell tipping point? In case you don't know about Malcolm Gladwell's work, this is his first hit book. So a tipping point, societies reach a tipping point when all of a sudden smoking is gross, that educated persons recognize that, we can't smoke anymore. I'm suggesting we're at a tipping point for the adoption of precision medicine. There is so much waste in the system. There's so much unexplained variation. There's so much clinical harm. We haven't been successful in going upstream to shut the faucet. We're plagued by depression, opioid abuse, alcoholism, and suicide. Life expectancy is in the wrong direction pre-COVID. All of this brings us to a tipping point. And I think this tipping point will result in the broad acceptance of the tenets of precision medicine. Let me show you how I believe we're going to get there. So look, for most people, It's still a deer in the headlights question. And this is a boy deer because of the antlers, of course. So I think this is still what the leadership of most hospitals and medical centers, they're still like the deer in the headlights, trying to come to grips with the pandemic and with unexplained variation and with precision medicine and where are we going? I get it. It's complicated. Let's see if we could create some take-home messages and then introduce, as I promised we would, the term precision population health. All right. So the main take-home messages, what does all this mean? I think there are three major themes moving forward. Let me take a sip from my Jefferson cup for a moment. I think those three themes are, as we've already advertised, going back to 1918 or even before that, transparency and accountability. Sunshine is the best disinfectant. To be accountable for what we do is true professionalism. And I believe we're heading to a world that we copyrighted this more than 10 years ago now, a world described by 4 words: no outcome, no income. Now, it may not be exactly like this, so improved outcome, more income, but I think transparency, accountability, no outcome, no income, a pretty good summary of where we are. And then finally, how do we get there? And then we'll introduce precision population health. Well, I think we have to change the basic culture of practice, and we have to do the following 5 things. We have to practice based on the best available evidence, recognizing that grade A evidence is only available about 18% of the time. We have to reduce unexplained clinical variation by closing the feedback loop and giving doctors good data in a non-punitive way about their own performance. We have to reduce adherence to professional autonomy. It's like Zen and the Art of Motorcycle Maintenance. Remember that great book from college? You got to give up some professional autonomy to achieve public accountability. And we have to measure and close that feedback loop. And of course, big topic for another time, we have to engage with patients in their own care. That gets me then to, what do we need? Well, I think companies like Genomind and others are contributing mightily to a new conversation. They're contributing to a conversation of, well, maybe the best way to treat depression is not a shot in the dark. Let's try this SSRI. If it doesn't work, we'll go to this one and that one. Let's get to the tools at hand and do genomic testing and reduce waste and reduce risk and get to the right drug to the right patient at the right time. So in my view, precision population health, it's a little clunky, I get it, but it gets us to where we need to be. Precision population health says, right drug at the earliest possible time, reduces waste and improves outcomes. We know this to be the truth. Precision medicine, importantly, reduces disparities in care. That's right. It tackles the severely ill through risk stratification, whether you're Black or white or brown. And more broadly, it tailors intervention to these high-risk groups. So I think it actually promotes health equity and reduces disparity if we could get these tools into the right communities. Another way to look at this, and this is right out of work from the American Hospital Association, go to the website that's noted here, take a look at this. But I love this term, precision population health, because it's the marriage. Remember, we set up friend or foe, and the answer, of course, is friend. Precision medicine and pop health are complementary concepts. And the outcomes gleaned from precision medicine fuel population health programs through the screening and risk stratifying. Then we apply the evidence-based protocols and off we go. So one more time, we could tackle depression, opioid addiction, suicide ideology, alcoholism, and many other social challenges using the tools of precision population health. And in so doing, reduce adverse drug reaction, that's important, reduce waste. And then the key for the future, speaking as a primary care doctor, the real future, I think, is here. Can we have offspring from the marriage of population health and precision medicine? And I see that the offspring, continuing this analogy, in primary care, the use of precision medicine in primary care, that's our biggest opportunity. So I'm excited about the future of primary care general internal medicine because we're going to have the tools available even in the office to do a genetic analysis, to focus our care for hypertension, for depression, anticoagulation therapy, and many other things that have been on the horizon for a decade. We are knocking at the door of this now in our ability to risk stratify, do a genetic analysis, apply evidence-based practice, and use the right drug at the right patient at the right time to reduce waste. It's a fantastic vision for the future of primary care. So talking about the future, I'm excited about what the H might stand for. Instead of just hospital, the H might stand for health. The H might stand for hope. The H is a whole new way of looking at, instead of building that bariatric surgical center and building that cath lab, the H is about hope and health for the future, a different way of looking what healthcare in America could really be about. Well, my final slide, I hope you appreciate this. You know, I've been at Jefferson on the faculty for 32 years. I boiled a lot of other faculty's bones in 32 years. That's how you survive fighting these giants on the right-hand side of your screen. The giants of, you know, we don't get it, quality, no one cares. I'm going to do what I was trained to do, fighting these evil giants and eventually boiling their bones. That's how you survive for 32 years in academic medicine. So colleagues, let me close by saying thanks again for joining us. Precision population health, the tools and technology developed and implemented in our country and in part by great companies like Genomind. I'm excited about what the future of primary care internal medicine might look like, and I'm looking forward to getting your feedback. Thanks again. And David, thanks again for having me.
Wow, that was incredible, David. When we were talking earlier, I told you that I heard Thomas Friedman speak the other day. And he has an incredible and uncanny ability to see the big picture.
Right.
And that's what you just did. You share that ability. That
Right.
was just incredible. And I would add that the H could also stand for heartening, because that talk was very heartening to me.
Great. I'll add that to the list. Thank you. That's a good one.
But, you know, some things that have occurred to me during your talk is we first met maybe 20, 25 years ago when I was doing vaccine research. What do we do when people don't actually want to accept quality care? When people, you know, refuse and deny the truth? How can we handle it? It's a rhetorical question, of course. I know you don't have the answer, but that is actually quite disheartening to me.
Well, let me tell you a story that's pandemic related, David. It's really fascinating. Lots of doctors, of course, especially primary care doctor colleagues around the country, refuse to be in a managed care setting with capitation and so on, at getting that per member per month payment. Lots of folks don't want to be in that role. About 4 or 5 months into the pandemic in 2020, let's say by June of 2020, we saw an unbelievable migration of primary care doctors who said they'll never accept capitation, wanting to be in a capitated environment. How come? Well, they were driven by economic factors. Offices that were based on private practice fee-for-service were closed and getting no income. And of course, weren't taking care of patients, weren't set up to do telemedicine. Folks who were in a capitated pay for outcome environment, who were receiving a per member per month payment during the height of the pandemic, they were thriving. So sometimes it takes a pandemic to get people to pay attention, on the clinical delivery side at least, to a different model of care. But that great migration from private practice fee for service, I'll never join managed care, it got a rocket booster as they wanted to be involved in an environment that promoted health, that paid them per month, and gave them the tools and the resources to connect with patients at the height of the pandemic. So it's been a transformational 2 years, that's for sure. And I think we're going to see, because of precision medicine, a new world order for primary care. I hope as this technology becomes more widespread, we'll be able to do these tests, get immediate results, give people the right drug at the right time. It's really exciting.
And just, a 1 second commercial about us. As a company, our model has been one physician, one patient,
One at a
one
time.
genetic test.
Right.
And we're now moving to population health, which of course is the reason that we asked you to join our SAB. And the way that we're going to do that is to we're going to ingest data from populations, be it a payer or an accountable care organization or a pharmacy or a large practice. We can look at all of the patients or members, look at their medications, and we can use our algorithms that Dr. Dan Dowd, who's on the line, has designed to predict what might be better choices for that patient. And then if you add in the genetic test, then we get down to the individual level. So next week, we'll be having an announcement about our first major foray with a partner into population health. So it's a very exciting time for us. And
really exciting.
I hope that it's also a tipping point for us as we move from one patient to populations. I have a question from a member of the audience. Thank you, Dr. Nash, for this insightful presentation. From your perspective, can you speak to more detail about who and how the major players in the healthcare system will drive the tipping point?
Well, at least as it relates to today, driving the tipping point toward precision medicine. Well, in addition to Genomind, of course, there are a score of companies working on genetic tests outside of psychiatry for all kinds of conditions. There's also a movement in the clinical laboratory. The movement is actually called Clinical Lab 2.0, where laboratorians are going to be engaged in precision testing. There's much more energy being focused on paying for these kinds of tests by the major for-profit, commercial, private managed care companies, by Medicare, by Medicaid. I think we will see a broader acceptance of paying for precision medicine in recognition that it reduces waste and, very importantly, tackles some of the disparities in care situation, which we did not go into in detail. So I'm optimistic that this movement, we're at the early stages of this. I know that we've been talking about precision medicine for at least 10 years, and certainly it goes back more than 20 years when Bill Clinton was president, breaking the genetic code and developing these tests. I think with PCR testing, post-pandemic now being used in other areas, the future is wide open for broader acceptance of the technology, which will have both anticipated and unanticipated positive impact on practice. And the fact that primary care clinicians of all sizes and shapes will be able to participate, to me, that's the most exciting part.
Well, David, you said that one of the points that you made was that the system of the current system we have of payers incentivizes them to have healthy members.
Correct.
If I were a cynic, which I sometimes am, I would say that it incentivizes them to have healthy members for 4 years.
Sure.
Because of the turnover in the system.
Sure. So there's a huge body of literature that tackles all of this. And yes, there is turnover. I think the best example to answer that specific question, David, is Medicare Advantage plans led in part by two major companies, United Healthcare, the largest in America, and Humana, number 2 in Medicare Advantage. At least in the MA world, there is no question that all of the social determinants get tackled: transportation, food, access, social systems. There's no question that they are totally aligned with improving health, whereas the rest of the system just doesn't operate that way. So, have we figured this out completely? No, but there is a groundswell of support for insurance that tackles all the issues we talked about in part 1, the issues of the social determinants, waste, and the four horsemen of the apocalypse. If we tackle all of that and go upstream, we will reduce waste, reduce cost, and improve outcome. So the evidence to support that would fill the room that I'm sitting in. Is there a worry about underutilization? There might be, but I mean, that's really pretty modest, and there's research evidence to support that that's the case.
One last question from the audience is, how do you see the use of AI as a driver to improve and assist physicians?
We didn't even
improving
talk
outcomes?
about AI and machine learning as a subset. Yeah. So look, wouldn't it be great if let's pretend I'm in a capitated environment. I have my panel of 2,000 patients and my payer is applying artificial intelligence. I come to work as a primary care doctor. I start the day and it says, hey, Dr. Nash, guess what? Your 30 patients with chronic renal failure, 5 of them had outside labs you don't even know about. Their creatinine is way worse, and they are on the road to dialysis unless you start doing something about it. Now, I can't wait to have AI that helps me to do that. Let's make a Genomind example. Hey, Dr. Nash, here's your panel, and we've applied some of Daniel Dowd's algorithms, and we see 10 patients who have had multiple ER visits for depression, including 2 hospitalizations you're not even aware of. Their medication isn't working. What are you going to do about it? Now, that's an algorithm that I would welcome to help me to do a better job. If I'm in a private practice fee-for-service environment, it'd be awfully complicated to be able to get my arms around that. If I'm in a team-based, capitated, global environment of care, and I have a team to help me tackle this, then I can practice population-based care and deliver the best possible care to these patients based on the algorithm.
Well, we've come to the end of what was a very rapid hour for me, and there's plenty of things we could still talk about. I'll just end by saying we're so proud to have you join our scientific advisory board. And
Thank you.
It's great. We look forward to the journey together with you.
And I
Thank you,
look
everyone,
forward
for
to
joining
coming
us.
back for part 2 anytime.
Thank you so much.
All right. Have a safe, great weekend. Thanks again, everybody.